Everyone. I'm Cynthia Charles, Vice President of Communications for the North Carolina Healthcare Association. I want to welcome you to our It Takes a Conversation virtual town hall. This is part of a series of conversations that North Carolina health system and hospital leaders have been having with the general public. And we're pleased to have a special guest joining our panel today. In addition to some health system and hospital leaders, we have Brandy Dawson from the North Carolina Rural Center you'll meet shortly. While our focus today is on building healthier rural communities, we know that you have many questions about COVID-19, so we'll be touching on that issue too. Our next program after this, which will be our final town hall of the year, is scheduled for October 7th. And the focus of that conversation will be on what's happening with mental health and mental health care in North Carolina. Registration for that program is currently open at nchealthcare.org. So we hope you'll plan on joining us for that one as well. So let's get started. I wanted to mention a few housekeeping notes. All lines will be muted during the program. If you have a question you'd like to ask, just submit it using the Q&A icon at the bottom of your screen. If you have any technical problems, you can send a chat to John Rao from NCHA, who is the event organizer. So we have a full schedule. We hope to answer as many of your questions as possible. And let's get right to it. I'd like to introduce you to Dr. Nisha Metta, who is a physician from the Charlotte area, as well as a writer and a speaker on many healthcare topics. She'll lead our discussion today. Thanks again for joining us, and I'll turn it over to Nisha. Thank you.
Thank you, Cynthia. Today, we're going to delve into what it takes to build healthier rural communities. North Carolina has 80 rural communities where health systems and hospitals help residents to get the care that they need close to home, including through innovative partnerships. We'll hear about some of the challenges rural healthcare systems face, as well as opportunities ahead to continue improving healthcare. Let's jump right in. We'll start with the big headline, COVID-19. With COVID cases on the rise, what are rural hospitals experiencing, and how are your teams working to keep their communities safe?
Hey, Dr. Metta, this is Chuck Mantooth. From my perspective up in Boone, I've used this quite a bit, that there's no smoking section of the plane, which basically means what probably most of North Carolina and maybe even across the country is experiencing in pockets, we're experiencing here. Maybe not to the level of some of the other areas, but we're experiencing a strain on our healthcare system that we've never seen before. I take that back. We did see it about 6 months ago. But one of the things that's different about 6 months ago to really right now is we have a few more tools under our belt that we're using here at Appalachian Regional. One is a lot more, I would say, upstream work, that as soon as we identify cases, we're trying to take those folks that are positive COVID, that have that diagnosis, identify through a screening process, what their needs, if it is likely to turn into an ED visit or even hospitalization. And we're trying to introduce any, through our primary care resources, any interventions that we can. One of the great ones that we're seeing, and it's really increasing, is the use of Regeneron, which is the monoclonal antibody. And as a physician, and Dr. Wells and Dr. Snyder know a lot more about that than I do, but it's been a really helpful tool anecdotally for us. And has been proven to keep some of the hospitalizations down here at ARHS. But, the other part that's important, and we have heard from a lot of our colleagues across the state, is our workforce is tired. It's like you went to battle 6 months ago, you got some rest, and now we're having to go right back to battle again. It's a little bit harder to do it that second time. So I know some of my other colleagues are probably experiencing the same things. But, that we're here, and we're weary, but we're still taking care of folks here in Western North Carolina.
Chuck, I'd echo a lot of the things that you just said. I think that we've done a lot over the last 6 months to prepare ourselves for hopefully what we weren't expecting, which was another surge like we're seeing now, through expanding our monoclonal antibody clinics and hopefully seeing the downstream effects of that. What I would add is just the acuity of the patients in a rural setting. That's probably our biggest challenge, is that we're used to high volumes, but those patients typically turn over in 3 days. You know, that's our kind of average length of stay. And what we're seeing now is these folks, when they come into the emergency department, they are acutely ill, much more so than our normal, you know, population. And then they're requiring much longer hospital stays, which I think that's where we're probably seeing the biggest strain, is that we're not able to admit and discharge at the same rate to provide care to other medical issues, because we're seeing such a high volume of COVID and these long lengths of stay. So that's been a real challenge for us. And then when you combine that with kind of the downstream volumes, or the fact that our tertiary care and referral partners their EDs are full as well, creates another level of complexity for us.
Nisha, I would add to what Chuck and Jonathan are saying. I definitely agree with all of those things. I do think that there is an issue with being able to get people to tertiary centers to make sure that they receive that higher level of care. I also agree that we are seeing sicker patients, and that progression to that severe illness is happening more quickly with the Delta variant than we are used to seeing with the wild type. I think someone asked the question, was Regeneron readily available? I think for the most part, we definitely have it here. I think Chuck just said that they have it there. Jonathan's system has it as well. I think it is readily available. I think it's a matter of people recognizing that it is available and us getting that education out to individuals so that they will know where to go, who to contact, and those types of things. And it does seem to help decrease hospitalizations, especially if you catch it before a person becomes severely ill. And so we definitely encourage people to seek Regeneron, that therapy, to try to allay some of the illnesses that we see, or the severe illness that we see with the virus.
Absolutely. I think there's a lot of common themes there. How are your hospitals supporting vaccine distribution, and what are you hearing from community members?
So for us, I mean, we basically, at the very beginning, when we received the vaccines, we stood up a vaccine clinic here on site, and of course, certainly went to various off-site areas to ensure that people received the vaccine. We made sure that we went to communities where there was a large influx of COVID or coronavirus infections. But here on our campus, we gave about 10,000 doses over a period of maybe 17 or 18 weeks. And then we went to schools and partnered with the school system, of course, worked with the health department to ensure that we were able to get vaccines to our communities. We work with our physicians now who are actually giving vaccines in their clinics. We work with mobile vaccine clinics to ensure that individuals have an opportunity to receive the vaccine.
I think that's amazing. You know, we had at our last NCHA event a few months ago, we had sort of discussed how that vaccine rollout was going. And I think the way that the communities and the hospital systems have been able to work together to really make sure that anyone who wants the vaccine has access to it has been really impressive. What can communities do on the community level to get this under control?
Yeah, so Brady Dawson here with the North Carolina Rural Center. I'll jump in and I think just add and echo all that's been shared here. And more importantly, that the community understand there's a role for everyone to play in that regard, that it is up to all of us to really support our healthcare providers and our healthcare systems and really tackling this new surge of COVID. And so with that, we've seen a number of faith-based entities and coalitions at a local level, at a state level, community and grassroots organizations really coming together to support our healthcare providers and systems and addressing the surge by encouraging more people on the ground in communities, especially people that are immunocompromised, to get vaccinated. And to try to dispel some of the myths around the vaccination and sort of what it means for communities and how it can impact not just an individual, but also a household. So getting the word out, dispelling those myths, and supporting each other through collective efforts is what we've been seeing and really supporting and advocating for.
I think that that is so powerful because, you know, I talk about a little bit how we as healthcare systems have been putting those same messages out for quite some time now, right? It's sort of, we're on repeat with the same messages, and people need to hear it in different ways, and having the communities out there really supplementing that information with personal anecdotes and things that speak to people is really powerful. I think that's been, especially with this newest surge, has been a powerful way to get at people who may have been not getting different messages earlier because it just didn't reach them in the right way that they needed to hear it. So I think that's been great. Moving on, let's talk about rural access. We know that there are a few factors that create challenges for rural communities. What are some of the challenges that your hospitals are working to address? Let's start with Chuck at Appalachian Regional Healthcare System. What is your perspective in developing and operating a critical access hospital?
Yeah, so a little bit about ARHS. We have we've taken advantage of the public policy more on the federal level. We have in our system really 3 hospitals, one a critical access hospital, sole community hospital at Watauga Medical Center, which is a status through CMS, and then also a brand new behavioral health hospital. It's 37 beds. So we've tried to follow, I guess, what's in policy form from a federal government standpoint. That's one tool or 3 tools that are available for us in a rural area to really kind of shape the care that's provided in those communities. But the question about critical access hospital, we've got some unique things going on at Cannon, at Cannon Hospital, which is in Avery County. It's in Linville, North Carolina. It's a critical access hospital. It's been around for decades, but we built a brand new facility about 21 years ago. And it's remarkable over that period of time. It was built for 72 beds. Over the period of time, we've seen the need for behavioral health care in our region in Appalachia go like this. And with the way policies have been formed around limits, 96-hour rules, and rules that have been put in place to really more around controlling cost, we've had to reshape our facility. And what we've done is taken that unique project. We've taken part of those beds that were built, converted them to behavioral health beds through support through North Carolina with Dorothea Dix funds, about $6.5 million there, and then really right-size our acute care down to about 8 beds. And what that allows us to do is to create really a good sustainable model for rural, at least the hospital side of care and that epicenter that you need for the community, a good sustainable model for us that really kind of adjusted and meets the 2 needs that we're seeing primarily here in our region.
Does anybody else want to weigh in about factors that create challenges for rural communities in terms of challenges that your hospitals are looking to address?
Well, I would add that, you know, when you look at challenges in rural communities, you really have to look at the context of your community. And a lot of our communities are aging. Because of a historical lack of access, individuals tend to be more sick in rural communities. We also are concerned about workforce issues. I would think much more so, or it's much more exacerbated in rural communities than particularly urban or suburban communities. And so those are some things that we are concerned about. And then when you look at the social determinants that really also add to an inability for people to receive access, you have to think those things through too. In rural communities, they tend to be exacerbated because of lack of jobs and those types of things. And so those are some of the issues that we deal with, but we look at them in a contextual way and trying to figure out what services are best for the communities. And, you know, one of the things that I've always said, and a lot of people do say, is that if you've seen one rural community, you've seen one rural community. Chuck's community is different from my community. Jonathan's community is different from Chuck's community. There is an underlying thread there, but for the most part, you have to really take into consideration the context of the community in which you live.
You know, what I would add too is looking for partnerships within the community. I mean, I think that's one of our biggest challenges is in terms of recruiting and retaining, you know, staff, meeting the needs of our organization, you know, looking at community partners. And I'll use the example of Surrey Community College, which is our local community college. We had a specific need for sterile processing techs. and we're having to, hire contract agencies to provide that service. So we reached out to Surrey community and said, can we develop a program in conjunction with you where we can, can train? And so, I think you have to leverage the resources in your community. And I think it's mutually beneficial. We will get into shortages, national nursing shortages, maintaining our nursing staffing. Well, we've partnered with our local nursing schools to really provide great rotations, and have had great success in terms of then recruiting those graduates because they're comfortable in our institution. So I think it's a win-win. They need clinical sites to rotate. They need to expand their options in terms of community education. I guess it's a three-way win. It provides jobs to the community because they have an avenue towards advancing their education. It provides the workers and the staff that we need, and it grows the institutions of learning. So I think really just partnering with community and really knowing what resources are out there is critical.
Yeah, you just actually segued great into the next question that I had, which, as you've mentioned, shortages in the healthcare workforce are part of rural North Carolina's biggest access challenges. How is it that we as a healthcare community can better recruit specialists and primary care physicians across the state? I know, Dr. Wells, that Cape Fear Valley has had a construction project underway for Center for Medical Education. Can you expand upon that project and give other insights that may be relevant?
Absolutely. We are really, really excited about what's happening here in our area, in our region, and the work that Cape Fear Valley is doing. We are in the midst of constructing a 5-story medical education building that will help undergird the strategy that we have here regarding medical education. We currently have system-wide 12 residency programs to include pharmacy residency, OB, internal medicine, psychiatry, general surgery. We have transitional years. We also have podiatry. We have stood up a cardiology fellowship under the leadership of Dr. Don Mahardy, our Vice President for Medical Education. And he's done a phenomenal job in really a short time in bringing those to fruition. We have a total of 70 graduates thus far, to include our transitional graduates who will be going to other places. But those graduates, we have about 30 who have completed their programs. And of that 30, we were able to retain 15. And of that 15, 8 of those are going to our rural communities. And so we really feel like this strategy is working well for us. Certainly we have Harnett Health now, which is a part of our system. Here at Hoag, we also have Bladen, and then of course we have the main hospital in Fayetteville. But we recognized, and our CEO recognized years ago, that if we were going to grow our specialty practices, we really needed to look at developing them in our area. And so that has been a phenomenal way for us to retain talent in our community. And so those are the things that we've done to retain and to build workforce. Like Jonathan, we work with the community colleges and the colleges here in our community to establish programs for allied health PAs, nurse practitioners, nursing students, or what have you. And so really, we really want to grow people here so that they can stay in the community that they grew up in the community that they love.
Absolutely. Chuck, can you tell us more about Appalachian Regional's primary care residency program?
Yeah, it's not to the scale that Dr. Wells mentioned, but here in the mountains of Appalachia, I would call it. I was sitting here thinking about our history, and 100 years ago, people lived in this area and didn't have access to a physician. And there are a couple of famous names that they recruited, and they probably got up here on horseback, and they became part of the community. Then they realized they needed a hospital, and then hospitals were built. And then now we're kind of back to, we need primary care. So that's probably, that front facing medical intervention to communities, especially rural areas, as our primary care physician. And what we have going on here is it's a partnership with MAHAC, which is supported through the AHEC system, but it's out of Asheville. It's basically a rural family medicine program. So it's family practice, but it has a rural, I guess, flavor to it. And how that starts with who we recruit and who we're part of the selection process, those that have a heart for rural medicine. And we've really seen that. We're in our second year. It's a 666 program. Eventually we'll have 18, obviously if you do the math, 18 positions. And then that's really springboarded really opportunities for other residency programs like family practice, a fellowship in sports medicine. So we'll have 2 of those next year. So we'll have 20, when it's fully mature, we'll have 20, I would say, postgraduate trainees here in our community. But they're really focused. The thing I really like about it is that we've selected people, as I said it before, that have a heart for rural medicine. Those are the folks that they have that heart. They train here. They typically want to stay here. And, you know, to being a little bit selfish, that's what we want to do. We want to create an opportunity to have them stay here in this community for their whole career, hopefully, but we'll see about that.
Yeah, let's move on to talking about innovation and collaboration. Those are 2 important topics that kind of piggyback off of these ideas, because rural communities are often smaller. They require collaborations with other healthcare partners, and that can really help rural patients to get access to specialized care. Let's look at the approaches to partnerships and ensuring that patients get accessible, affordable care close to home. Paul, I know that Hugh Chatham has a great partnership with Allegheny Health. Can you tell us a little bit more about that?
Sure. Thanks. So, you know, really in rural health, you know, we have to be willing to innovate. We have to be good stewards of our resources, and it requires smart partnerships. So Allegheny Health is a critical access hospital in Sparta, North Carolina, that was really in a position where they were unable to provide sustainable health care in that community, which that community needed. So the hospital and clinics were purchased by a joint venture between Hugh Chatham Memorial Hospital and Wake Forest. And it's governed by a joint venture board, which is separate from the parent organizations. Really through a community-led effort, they were able to raise around $6 million for building a new medical office building and for essentially renovating and rebuilding their entire facility, able to co-locate their inpatient beds into the ED, which really provides a more efficient facility, an improved staffing model, and a facility that really mirrors the community needs. So that's the facility and infrastructure part. Where we get even more value from the partnership is our ability to provide providers. So part of the new medical office building will be consolidating multi-specialty outpatient clinic with specialists from both Hugh Chatham and Wake Forest. So we have cardiology, gastroenterology, orthopedics, general surgery, podiatry, from various institutions that are able to come there and provide their services, you know, in the rural setting in Allegheny County. And I think it really just brings together the best of kind of the academic quaternary medical center with a high functioning community hospital to meet the critical access needs of Allegheny County and those surrounding communities.
Yeah, and sorry, Dr. Snyder, I called you Paul by accident. I apologize for that. Dr. Wells, can you share some of your thoughts on the partnerships at Cape Fear Valley Health?
There you go. Certainly. You know, I think we have to think in terms of rural hospitals that are connected with systems, and then rural hospitals that are, you know, considered sole or independent facilities. I happen to be a rural facility that's connected to a system. And so with that, you know, we do enjoy some privileges, I would say, that sometimes independent facilities don't necessarily have unless they have a specific partnership like Jonathan discussed. But nonetheless, even with those partnerships, it's important to remember that a lot of the issues associated with rural care really boils down to social determinants and people and how the access they have before they get to the hospital. And I think that, that's an important piece to remember. I am very fortunate that I am not very far from our flagship facility, which has trauma and, most of the specialties that people need. But at the same time, we have to remember that the community piece of it is extremely important as well. And those social determinants play a huge role in the care that people receive and the care that they seek. Sometimes education and not understanding what's available to them is important. So the rural care is multifaceted, and it's important to remember that there are differences in whether you're connected to a system or whether you're affiliated with a system or whether you're independent. But nonetheless, I think that those determinants, those social determinants, play a role across the board.
Yes, absolutely. So across the state, telemedicine use has soared because of the pandemic. This has particular benefits for rural communities. Can you talk about why? And actually, can you, Dr. Snyder, can you start with sharing some of the successes at Hugh Chatham?
Sure. I mean, I think we all, in the press, we've seen, this big expansion of telemedicine through COVID. I think we're all aware of that, and I think that it has changed the way that we're delivering care in our primary care practices. But I want to take a step back and really look at how telemedicine has affected our ability to provide care in a rural area prior to COVID. So we were the first primary stroke center in our area, and that would not be possible without telemedicine. We have, board certified neurologists on staff, but, for us, we don't have a team of neurologists. We don't have enough coverage. He can do, his part, but it requires collaboration. And, we work with Novant Teleneuro to provide that 24/7 coverage so that we can, provide, primary stroke center level of care to our community. And so that's exciting. As we moved into COVID, and we expanded our telemedicine access across our kind of ambulatory footprint, one of the areas where we really had the biggest impact is in behavioral health. We're lucky to have board certified psychiatrists on staff, which is not common in a lot of rural communities. And we have a licensed professional counselor that works with in the practice. And so they went to 100%, televisits during COVID early on. And what they saw was amazing: improved compliance, decreased no-show rates, and better clinical outcomes, because it really, just coming to the office for that patient population was a barrier, to access. By being able to set up these televisits, it really improved their practice. And actually, as we've moved through COVID and many of our ambulatory practices, transition back to a more normal care delivery model, if you will, in office visits, they've really stayed greater than 90% televisits because they're seeing better outcomes. Their patients like it, and it's been a big benefit. It really breaks down the ability to have transportation or really even kind of geographic limitations to have those televisits available. So some of these things are pre-COVID, and some of these we've learned as we were forced to with COVID coming on.
Absolutely. Did anybody else want to weigh in on that before I move on?
Nisha, I will add that probably about 4 years ago, we set up infrastructure in our rural hospitals using a tele-nocturnist program, which would allow us to have a hospitalist in the hospital during the day, but then have a nocturnist cover for us via telemedicine at night. Initially people thought, well, in a rural community that will never work because people are used to seeing, touching, or what have you, their physician. I can tell you that it has worked extremely well. Our patients actually interact very well in an inpatient setting with those providers. And just as Jonathan has stated, we use telepsychiatry in the process of starting teleneurology. And what telemedicine does for rural communities is it gives us the opportunity to provide access to specialty care that we typically would not. The other thing that we're doing now, particularly during the pandemic, is using critical care specialists via telemedicine to help us care for patients that are in our hospital. We're all seeing that we are not able to transfer people as readily and as quickly as we'd like because the tertiary centers are full. So what better way to leverage telehealth for the good and the benefit of the people that we care for than allowing a critical care specialist to help oversee the care of those individuals in our hospitals, and they get to stay in their communities as well. And so those are some of the ways that we are leveraging telemedicine here in our health system.
I love that. I think being able to stay in your communities is so powerful when we talk about health, comprehensively and start thinking about what patients need, having their families nearby and having their support systems nearby and still being able to get top level expertise in things that where we may have some shortages in rural communities in terms of specific experts, and just being able to leverage all of those things together, I think is really amazing. And hopefully the power of technology will just continue to increase the opportunities for being able to bridge some of those gaps and deliver care where patients need it the most. I'd like to shift to the needs of rural communities. We know that these areas have higher rates of chronic disease and population health is a big focus. How can hospitals help patients address barriers like poverty, access to healthcare, and more? Brandy, we'd love to start with your take on this.
Yeah, so I do think there are a number of health systems across the state have done a phenomenal job, seeking to really address social determinants of health. I've had the honor and privilege of working with a number of those healthcare providers and entities across the state. And just as some of the key examples of the type of programming that they've either implemented themselves or partner with other organizations and entities in their communities to enact include everything from expanding a community health worker model, so identifying local people in communities that have those relationships, particularly with individuals who may not be as used to or interested in engaging a healthcare system or provider, and connecting with people that they already have relationships with, people they're familiar with, that can help them kind of navigate the process and understand kind of the nuances of navigating the healthcare system. Additionally, addressing issues around access to healthy foods, which we know is a huge issue across rural North Carolina, particularly access to healthy food and in places that are really close proximity to where people live. And there are some communities, no surprise to anybody on this call, that don't even have access to a grocery store. And so that really obviously presents huge barriers when we talk about people eating healthier and getting healthier to addressing those chronic disease issues. So I've seen healthcare providers and systems host their very own food banks, their food clinics, farmers markets, partnering with local farmers to provide food boxes to patients as a way to kind of prescribe healthier eating, but literally providing them with the food to be able to do it. And some even going a step above beyond that, which is, you might give me a squash, but let's show me how to use it. Like, what am I supposed to do with this, right? And so providing not just the food, but also the educational components to understanding how best to utilize that food and eat it in a very healthy way. Other examples that we've seen is, other programs around healthy lifestyles, where there's access to recreation programs, by providing sort of Zumba classes and things of that nature to kind of show people directly ways that they can become healthier. So I think those are really some concrete strategies we've seen put in place. And beyond that, I think the advocacy that goes with it. So training community leaders on advocating for programs and policies that will really seek to move the needle and address some of these policy level issues addressing and plaguing communities when it comes to poverty and other social determinants of health.
Absolutely. Meeting people where they are is so important. Dr. Wells, your hospital has some interesting partnerships with schools and community organizations. Can you share some of that perspective on preventative care?
Well, absolutely. Truly, I think, and Brandy did an awesome job in explaining all of the things, and I would definitely piggyback on those things. But when you start to think about preventive measures, you have to think about education and how you educate the general public, whether it's educating people on how to recognize a stroke, educating people on how to recognize, a heart attack or what have you. You have to really work on education. And so that education goes in a myriad of directions, not just from, formal education through schools or what have you, but you've got churches who are very, very interested in sharing information with their parishioners. You have other agencies and organizations that are grassroots agencies and organizations that share information with their communities. The truth of the matter is, in rural communities, you really have to be grassroots. You can't be, conceptual. You have to be grassroots. And I think that if we recognize that and really leverage those organizations in our community that have been there for a very, very long time, and really leverage them, bring them together. The hospital can serve as a convener for those groups, bring those people together and let them do what they do extremely well and support them in doing what they do, rather than taking over the job of doing what they do. Give them the support that they need and fill in those plugs or those holes that might be present, but really utilize and leverage the people in the community who are already doing the work, who already have the trust of the community. I think that those things are very, very helpful, particularly when it comes to prevention, to include vaccination for COVID-19.
Absolutely. A related question from Elena: what about partnerships with home health care agencies like hospice, home health, private duty nursing? This kind of goes back a little bit to just access and partnerships, but I don't know. Chuck, we haven't heard from you in a little bit. Do you have anything to say about that at all, or anybody else who wants to weigh in?
Yeah, I mean, those are easy. Well, not easy, but these have just been partners that have been part of our care model for years, which I will probably pull one out of there. Hospice has been, we've recognized the need to try to go up as far as we can with at least talking with folks about, this end of life situation. In hospice, we have a really good partnership with Caldwell Hospice here in Boone, where they'll actually will do a lot of that work with us, with our primary care physicians. And, unfortunately, if it does get to a hospital setting to where it does look like that's the path that someone's on, they'll work hand in hand with us to make sure that they're a valued partner, to make sure that experience is for the family and for the patient is as good as it can be. So, but access to home health, and we actually built a skilled nursing facility 4 or 5 years ago. We ended up selling that, but for other reasons, for it to be developed. But that's something that we started, that we handed off to someone else because they had a really good way of doing that. And it's just become part of our community. So, hospital care used to be somewhat isolated, but now we really depend on all those agencies within our community to really just kind of make sure that it is just a nice seamless continuum. So
that's actually a great transition to just what communities can do to support their local hospitals, right? Instead of just a one-way hospital supporting communities, what can communities do to support their local hospitals? Brandy, can you talk about the connections between just strong hospitals and economies and the reasons why that might be of interest?
Yeah, and we definitely at the Rural Center see our hospitals as key anchor institutions in communities. The work that the folks on this call are doing and other folks across the state are literally saving lives. We've seen hospitals move from a primary focus on, sick care to preventive care, recognizing we got to meet people much earlier. Dr. Wells spoke to this earlier in the call, which was that we know that populations in rural communities are older, they tend to be sicker, and they tend to take a little bit longer to get to, hospital when you do get there, and they're in a much worse condition. And so utilizing, I think, the opportunities in communities like our school systems, our community colleges, and grow the pipeline of future, I would say, say healthcare leaders are going to stay right there in their local communities is very key. We've seen that, potential implications for hospital closures across the state and what that has literally done to a local economy and a local community without having access to a hospital. Not just the economic impact, but also the human impact that goes with hospital closure. So we see a direct connection there, and we encourage folks to engage their state and local elected officials about the needs of their local hospitals, the idea and the opportunities to grow the pipeline of healthcare workers across our state as well, and to do that much earlier in communities also.
How can more rural North Carolinians get access to and coverage for care?
Yeah, that's a great question. I think speaking to the amazing healthcare systems that we do have in our state, not just at the hospital level, but primary care providers or FQHCs are doing an amazing job. And the opportunities for them to provide and supports for uninsured and underinsured individuals is great. And it really is demanding and taxing on the economy and the impact of the local hospital and those systems. So we have been and will continue to advocate for closing the health insurance coverage gap in North Carolina to really meet the needs of our state's uninsured individuals across the state who deserve access to affordable, high quality care and being able to access that in a very affordable way. And so that to us is seeing one, I think, policy implication that will have generational impacts to come.
Absolutely. I want to move on to some of the audience questions, that some of which have been pre-submitted and some of which have been submitted during the course of this conversation. I want to start with a question from Gina from Charlotte, which is, the US spends more on healthcare than any other country. How do you propose to reduce healthcare costs?
So, Nisha, if I may, I'd like to take a swing at that question. One of the ways that I think that we can reduce healthcare costs is ensuring equitable care to all, ensuring basically that no one is left behind when it comes to healthcare, and making sure that we decrease or, we stop or discontinue barriers that people are facing. And, we often think of healthcare disparities in the form of race and ethnicity, but I also believe that there are geographical healthcare disparities as well. And if you put the three together, you basically have a trifecta. So if you're in a rural community and then you are ethnically or racially, if you fit into those categories, there is a trifecta, and it does add to the cost of healthcare across the nation. And we're not just talking about dollars, but we also have to realize that that cost of healthcare also includes the cost of lives, human longevity, morbidity, mortality, those types of things. And so, one sure way to ensure that we decrease the cost of healthcare is to ensure that nobody is left behind when it comes to access to care, receiving care, how that care is paid for. Those things are really, really important. We've addressed a lot of those things today. Brandy has talked a lot about those things today, but I've always felt this really since the beginning of my career. You have to address the disparities in healthcare if we are going to adequately address the cost of healthcare, and not just in dollars, but in lives as well.
Yeah. Does anybody else want to weigh in on that before I move on?
Yeah,
Maybe-
Nisha,
Go ahead, Dr. Snyder.
I'd be happy to. We know that in general numbers, somewhere around 5% of patients in the U.S. generate over 60% of the cost in healthcare. So we know that they can be treated or cared for more effectively. And many of those folks have chronic medical conditions that utilize, our EDs, as, for their primary care source. And we know through, population health, things like ACO, like our partnership with CHESS, we've made a big, move in our local population. And it's really through coordination of care from a, multidisciplinary, care team with pharmacists and nutritionists and therapists and case managers that we're able to, effectively care for these, give them a better quality of life, and really bring the system to them rather than them waiting, and ending up in the ED. And I guess at the end, it's in a way, what I like to say is, it's easier to put out a campfire than a forest fire. So if we can bring this to them, make access easier, give them the resources. Within our ACO, pharmacists that coordinate getting the patient's medications, sometimes at less or cost than what they would have to pay, or free, and they'll use it, and they have people following up with them. So it all works. What Roxy said, it's all about bringing the access to the patient and caring for them, real time, rather than waiting for things to fall apart. So,
Chuck, I know you'd wanted to weigh in. It sounded like you want to.
Yeah, I'll be brief, and maybe I'll get a little bit on my soapbox here. But I think we've as healthcare leaders for years, we've watched as we know issues like, let's take smoking, diabetes, obesity, those type things, and we kind of know what's contributing to those things. But in my opinion, I think one of the things that's lacking is just clear policy from a federal level. That what I'd really like to see, if I were putting this problem in a vacuum, is really kind of folks putting things aside and really focused on what is best for our country, to tackle this issue, to bring the cost down and improve health. To really kind of take that and put in policy form of what we want to accomplish. And let's try to agree on that. Now that does sound like a little bit of a dreamer, and I realize that, but we kind of know what those tools are. And the second part of that is take payment and align it with policy. That, to me, until we get those things accomplished, we're just kind of chipping away at the fringes. I think that's really kind of the heart of it from my perspective.
Yeah, Nisha, if I may add just quickly, I agree totally with Chuck about policy and advocacy and making sure that, from a legislative standpoint, that people understand truly what's happening in rural communities and really adopt policies and adapt policies to help our communities. I think Chuck hit the nail on the head in aligning payment to those policies and what the expectations are. So I'm in total agreement with both Chuck and Jonathan.
Somebody had touched earlier upon mental health care issues, and we know that, across the country, particularly in this pandemic, we've had a real shortage in sort of access to mental health care. Allison from Burlington was asking, are mental health care issues in rural areas different from city/in-town problems, or just approached differently? Does anybody want to take that?
Well, I'll take a swing at it, but I think Chuck, having stood up a behavioral health center in his community, is commendable. The one thing I will say is that, I believe that the issues are basically the same, but they're exacerbated in rural communities because of lack of access and follow-up care or what have you. One of the things that I've noticed is we might get an involuntary commitment here in our hospital. We may have that patient for an enormous period of time, finally get them to a center for treatment, but then when they return to the rural community, they don't have the access outside of what we now see as the telemedicine use that Jonathan talked about earlier. But those, for me, that's one of the biggest issues that I've seen in this facility and prior facilities. But I know Chuck and his team, they have really taken the bull by the horn to work on this. And so I'll stop there because I know he or Jonathan may have some additional thoughts about that.
I'll just jump in, Dr. Wells. I'll be brief, but yeah, we built out, I think, kind of the end result with the behavioral health beds, the inpatient side. But a few of the things that we're doing, they're a little bit unique in the community, especially for rural areas. That question's a little tricky because I don't have the perspective of what's going on in urban areas. But Appalachia has historically been plagued with substance abuse, and what we've tried to do is look at upstream a little bit more. I know we're talking a lot about upstream, but there's a program called ACEs. Like, it really is asking the question, what happened to you? Looking at kind of those early childhood issues and how do we prevent those? Because typically what's seen is that something happened to someone as a child, and if you let that go over a period of time, it really results into a behavioral health issue. And the great thing about, this is not my idea, by the way, but we're taking the ACEs learning and we're integrating that into our primary care rural track. So we're training physicians early on how to manage that early on. So we hope, decades from now, we'll start seeing that process that we've started right now actually taking place. So hopefully I'll be around long enough to see the result of that. But we've got to start thinking that far ahead to make life better for those that come after us.
Did you have anything to add, Dr. Snyder, or do you? Okay. I'm going to go on to the next question, which we've alluded to a little bit in terms of just how much telehealth has grown over the last few years. Warren from Statesville is asking, how do you see telehealth being used in the next 5 to 10 years? Does anybody take a chat? Dr. Snyder, do you want to weigh in on that?
Sure. I mean, I think like Chuck and Roxy have said, I think it just improves access. I think it improves service lines in terms of it's a place to begin. If you're looking at intensivist care or hospitalist coverage, if you don't have that or are challenged, it's a way to supplement the care that we provide within our organizations. And when we see a community need, if we don't have boots on the ground, providers in that area, then it's working through partnerships to identify, sources that can provide those tele services. If those services are proven, then kind of at the same time you can work on real-time recruiting for permanent staffing in those areas. So absolutely it will grow. In our primary care, I think one of the big things is looking at integration into our EHRs to make it easier. I think a lot of times, where it wasn't being utilized, then it's trying to make a system work, whether it's your basic EHR and then a Zoom call. I think we have a lot of work to do in terms of reaching our most at-risk population through teleservices. Really our aging population that either don't have access to, or all of our community that do not have access to, the iPhones and iPads and computers or know how to. One of the things that we've done that's been a great benefit is utilize our home health services. So when the home health provider is out in the home, they all have iPads and they're able to kind of set up that televisit at the same time. So, it's learning new methods of care that are outside of the box. And I think we've got a lot to learn, and I think there's a lot of opportunity as well.
I'd love to touch. Oh, sorry, go ahead. Did you have something to say?
I just would like to add one thing to that. Definitely telehealth is excellent and it does provide access, but simultaneously, I think it's extremely important. Not only do we provide access, but we provide high quality care, and that we look at metrics from the telemedicine world to make sure that not only are we just providing the access, which is definitely what we need, but we need to provide high quality care. And I think that we really simultaneously need to think about metrics that will ensure that we are providing that to our rural citizens.
I wanted to ask, actually, Taylor Knopf, reporter for the North Carolina Health News, is asking, what are the vaccination rates amongst your hospital staff? And are you doing vaccine mandates? How do you intend to combat the potential staff shortages during an already strained time?
Anybody want to take that?
Yeah, I'll go. We started probably 2 weeks ago. We were at 70%, and we also wanted to understand kind of what percent of our population also had COVID positive, and maybe it had some antibodies. That was about 10%, so 80%, some level of antibodies, and that's increased. What we've done is, because we are in a workforce crisis, we were concerned that if we made a mandate at this point without FDA approval, now that's changed a little bit. We're reevaluating our policy right now, but it has increased. We're making people, where N95s, we also said, look, if you're not getting vaccinated at this point, we're going to wait till FDA approval, but we have an obligation to the public to maintain a safe environment. So if you're not vaccinated, then we are making you wear an N95 the entire time that you're here at work. So that's an interim policy, and I know the FDA just approved Pfizer just a few days ago. So we're reevaluating our stance on that right now.
So for us, our health system has mandated vaccination, and we mandate full vaccination beginning October 1st. So we are in the process of increasing our employees. We're at about 76%, maybe 78% now of individuals who have been vaccinated. Of course, there are the two potential exemptions, the medical exemption, people who have allergies to the vaccine or what have you, and then religious exemptions. But those things are being looked at on an individual basis. As Chuck stated, we want to make sure that our public is, that the people who come to our facilities are safe. We also want to make sure that our staff is safe as well. I have full faith in our staff. People, now that we have the full FDA authorization, I think we'll see an uptick in the number of people who have been reticent, particularly in healthcare. There will be, or there may be people that we lose because of the mandate, but I think for the most part, we will fare well in our population here.
So Nisha, I think setting context is important. Surrey County, we're the sixth highest in the state in terms of transmission rates. And we're also at the bottom in terms of vaccination rates of our community. I think we've just broken 40% in our county in the last week or so. So that's our community. Within the hospital, we're a little over 50% vaccinated in the organization. We continue to educate, and we've creative ways of we have multiple providers who are offering and providing one-on-one discussions, private conversations with any organization member who would like to discuss the vaccine. Trying to get past here are the numbers, here's the science, just presentations, and really having honest conversations with the members of our organization and really the community at large to encourage vaccination, knowing that's how we're going to turn the tide of COVID.
Absolutely. Well, we are running out of time, so I want to ask one more question, just so people can get to know you all a little bit better. We'd like to ask everyone what inspired them to get into healthcare. Would anyone like to kick that off?
Well, I don't mind kicking that one off as the only non-practitioner on the panel, but nonetheless, I definitely consider myself a community health advocate. Coming from a family of public servants, nurses and social workers and teachers and the like, I knew that I wanted a career that would allow me to advocate for and potentially speak on behalf of our state's most vulnerable. And I would say throughout my career, I've had the wonderful blessing and opportunity of doing just that. So while I'm not a practitioner, I've had the opportunity to work alongside a number of practitioners on the ground. I've learned a lot about the work that they do day in and day out and have much appreciation for that work.
I'm happy to go next. Really, my mom, and I always say her name in presentations, she's deceased now, but Margaret Cannon served as an apprentice midwife for years. I grew up in rural Alabama, and she, back then, the family doc trained members of the community to do deliveries. And while she didn't have formal education, she loved medicine and loved healthcare and was just very dedicated to ensuring good outcomes for mothers and babies of color. And I just remember seeing her go out all times of night, go back to homes to make sure that moms knew how to breastfeed properly and those types of things, even back in the 70s. And so that, for me, was how I got into medicine. So.
Chuck?
Yeah, I hate to have almost the same answer, but I would say my mother. She worked at a hospital. She's much smarter than me. She never had the opportunity to work beyond a position that she had in medical records. So she grew up pretty modestly and always wanted us to do a little bit better in education. But also my dad too. My dad passed away at a pretty young age, and that kind of inspired me to, try to make a difference on that side. And then lastly, I would say that my faith is pretty important, and that's kind of the sustaining factor, and really kind of just trying to live out my responsibilities there to care for others. So those three things I would say.
Dr. Snyder?
Yeah, I'm going to answer this question a little differently, because what I want to answer is why I am where I am as a provider. And the answer is I'm home. So I grew up in this community, and it is used to be a 6,000 person town. It's probably now a 4,000 person town. It was, booming textile town. Now it's not, and there's been this mass exodus of young people and, folks going off to gain education and then not coming back to their home communities. And, as I was, I kind of always thought that I was going to be an academic joint replacement surgeon and do research. And, and then, my father, had a terminal illness. And so my mom was here, no other family. I thought about what really should I do? And there was this epiphany of going back home for a lot of reasons, to give back to the community that really got me where I am today, and to be able to provide care. I've taken care of second grade teachers and principals and church members, and get to have consults at the grocery store every week. So I mean that's kind of the important thing to me, and I think that ties into our conversation today about the resources and getting folks back into their communities, or not losing the community resources. So yeah, I'm back home.
Well, that's all the time that we have, but I'd love to thank our panelists. It's been an absolute pleasure. Brandy Bynum-Dawson, Senior Director of Policy Advocacy for the North Carolina Rural Center, Roxy Wells, President, Cape Fear Valley Healthcare, Jonathan Snyder, Chief Medical Officer at Hugh Chatham Memorial Hospital, Chuck Mantooth, President and CEO, Appalachian Regional Healthcare System. I'd also like to thank all of you in the audience. And if your question was not addressed, please send an email to communications@ncha.org. Today's conversation has been recorded and will be available for viewing or listening at nchealthcare.org. So please share with your community. My name is Dr. Metta. Thank you for attending, and join us next time.